When we discuss the physiologic effects of the birth process on the mother, we must explore how her reproductive system changes in response to labor. The most obvious change occurs with the characteristics of contractions. Normally, these tightenings of the uterus are coordinated, involuntary, and intermittent. The uterus, like other smooth muscles in the body, can contract and relax in an organized way, gradually becoming more regular as the pregnancy approaches full term. To measure contractions, we discuss their frequency, or how often the contractions happen, their duration, or how long each contraction lasts, and the intensity, or the relative strength. The involuntary nature of the contractions means that the mother has no real conscious control over the labor process. She may facilitate the process through her actions and psyche, but ultimately labor results in the mother as a passive participant. When we describe contractions, we discuss the cycle in which they progress. The increment, or building, begins the cycle with the myofibrils of the uterus contracting together in the fundus, or top of the uterus, most near the maternal xiphoid process. Spreading throughout the uterus, the contraction reaches its peak intensity, or acme, then gradually decreases, known as the decrement. The interval between contractions is the time in which one contraction ends and the next contraction begins. When palpating the uterus during the interval, we determine how relaxed or soft the uterus becomes. This allows the nurse to determine the resting tone of the uterus. This is an important component of the nursing assessment of labor. The entire cycle may be palpated by the nurse to determine frequency, duration, and intensity. Intensity, where we determine whether a contraction is mild, moderate, or strong, may be measured objectively. When palpating the fundus, the nurse may note a mild contraction, which feels similar to the tip of the nose. A moderate contraction feels similar to the chin, or a strong contraction feels like that of the forehead. These clues help the novice nurse to improve her labor assessment skills. Changes in the shape of the uterine body serve several purposes during labor. First, the upper two-thirds actively contracts to push the fetus down. The lower third, along with the cervix, or lower opening into the uterus, passively allows the descent. Second, the myofibrils in the fundus maintain a shorter length at the end of each contraction cycle, while those in the lower segment remain longer. This allows tension to remain in between contraction cycles to preserve both cervical change and downward progress of the fetus. Third, these changes in the myometrial cells cause the upper segment to become thicker in shape, while the lower segment of the uterus thins out and is pulled more upward, thus allowing a more narrow, elongated uterine shape. This elongation helps to straighten the fetus for improved efficiency of movement into the maternal pelvis. For the fetus to exit the uterus, several changes in the opening to the uterus must take place. The cervix, which marks the doorway into the uterus, must gradually alter its shape to allow passage of the fetus. These changes occur concurrently and are known as effacement and dilation. Effacement is the physical thinning or shortening of the length of the cervix. It occurs from both pressure of the fetal presenting part on the cervix and the gradual upward pull on the lower uterine segment. In most women, cervical length is about 3 centimeters long. To understand effacement, see yourself putting on a turtleneck shirt, as the length of the neck piece may be compared to the length of the cervix. As you gradually push your head through the neck of the shirt, you have less fabric in front of your head. The baby's head acts similarly on the cervix as your head acts emerging through the turtleneck. Effacement is the percent of the cervix that has thinned. 0% effacement means no thinning has occurred. 50% means that 50% of the cervical length has dissipated. 100% is the maximum measurement, and it describes a cervix that is now paper thin. Dilation measures the actual physical opening of the cervix from 0 to 10 centimeters wide. Often thought of as concentric circles, the circle widens as the fetal head passes through. Both effacement and dilation are measured using a sterile gloved hand into the vagina. It is important to recognize the changes that take place during labor in the maternal cardiovascular system. As the uterus contracts, the blood that normally perfuses the fetus through the uterus into the placental bed no longer can travel along the uterine vascular bed. This has two outcomes. First, during contractions, 300 to 500 cc's of blood is temporarily diverted back into the maternal vascular system, thus increasing her blood pressure and lowering her heart rate. Of note, if the blood cannot reach the placenta, the fetus does not receive perfusion during the contraction. Thus, a healthy placenta maintains a well of oxygenated blood within its sinuses to allow for fetal survival during the labor process. A second outcome on the maternal cardiovascular system is the need to minimize supine hypotension in the mother. Significant hypotension resulting from suppression by the fetus on the vena cava may occur. As the woman's blood volume increases during pregnancy by 30 to 40%, a woman who is anemic when labor approaches may have a much more difficult time with excessive blood loss during the delivery. Changes in clotting factors, particularly elevated fibrinogen levels, allow for hemorrhage protection. However, this increase occurs earlier in the pregnancy and does not change immediately upon delivery. Thus, screenings for both DVTs and pulmonary emboli is imperative. Of note, elevated white counts as high as 20 to 30,000 can be seen in labor. This is a common finding and is probably a maternal protective effort from the rise in catecholamines often accompanying the labor process. The next few slides will demonstrate the interrelationships between the four P's of labor. The powers, passage, passenger, and psyche all play integral roles complementing each other in order to have a successful vaginal birth. The first component in the birth process is the power of labor. There are two distinct powers, the first active, the second passive. The passive power is the uterine contractions that force the fetus through the birth canal. It is called passive in that it is involuntary and an unconscious process that occurs within the mother. The active powers are the maternal pushing efforts. These are the primal reflexes experienced by the mother to bear down when the fetus reaches a point in the birth canal. These are typically described by the mother as rectal pressure or an urge to evacuate her bowels. Typically, labor is well advanced and the cervix is dilated to 10 centimeters before this urge appears. Probably the most unforgiving of the four components is the passage. This describes the maternal bony pelvis and the surrounding soft tissues. As the tissues give and stretch to accommodate the fetus, the pelvis is usually a more troublesome component. As the hormone relaxes and increases during the end of pregnancy, it softens the maternal joints in order for slight flexibility in the pelvis. Understanding that the pelvis is divided into parts that create a curved cylinder, we may judge progress of the fetus through the birth canal based on landmarks within the pelvis itself. The fetus travels through the true pelvis, entering into the inlet, passing through the mid-pelvis, and descending from the outlet. Each area of the pelvis has different widths and turns that the fetus must navigate using what's known as the cardinal movements. We will discuss these movements later in the slides. The passenger is considered all components of birth within the uterine cavity: the baby, the membranes, and the placenta. The fetal head usually enters the birth canal in a cephalic presentation in about 96% of labors. Presentation is determined by what part of the fetus enters the pelvic inlet first. Cephalic means the head, Shoulder would indicate a shoulder, and breech means either buttocks, foot, or a combination of both. We determine cephalic presentation by recognizing landmarks on the fetal head. The sutures and fontanelles that exist on the fetal skull give us a road map to the way the fetus is facing. We will explore this and other variations of the passenger in depth. When discussing lie, we must determine the orientation of the long axis of the fetus to the long axis of the mother. Consider the axis as the spine. Parallel and longitudinal lie occur in almost all pregnancies. Whether breech or cephalic presentation, the axes are parallel. In picture A, we see a cephalic presentation with a longitudinal lie. In diagram B, we see a back presentation with a transverse lie. You can see the perpendicular fetal orientation to the mom's long axis in the second picture. Attitude describes the relationship of the fetal body parts to one another. Are the parts flexed together, as in picture A, or are the parts extended, as in picture B? Normally, the fetus takes the flexed attitude, body curved forward with a convex C-shaped spine, hence the name fetal position. Fetal attitude can greatly impact success or failure of a vaginal delivery. A flexed attitude allows for an improved fit within the bony pelvis. This slide demonstrates the various cephalic presentations possible during labor. A flexed attitude is more desirable than an extended attitude, particularly when a cephalic presentation exists. A full extension, otherwise known as a face presentation, almost always results in a cesarean birth. Breech presentations are described according to where the legs are positioned in relation to the fetal body. The most common is frank breech, where the fetal legs are extended across the abdomen toward the shoulders. This is the position that, for obvious reasons, can have the greatest cause of fetal hip dysplasia, where the hip joint fails to form completely. Fetal position is often the most difficult for students to understand. It describes the location of the particular part of the fetus that presents into the maternal pelvis and relates that fetal part to the 4 quadrants within the pelvis. It is often described in 2 or 3 letters and can change as the fetus descends, turns, flexes, and extends while moving through the pelvis. The first letter often describes which side of the maternal pelvis the presenting part enters, either the right or left. If the presenting part is more to the maternal spine or posterior portion of her pelvis, then it is a right or left posterior position. When located in the front or near the symphysis of the pelvis, it is an anterior position. The second letter determines what part of the fetus is presenting, whether occiput, brow, mentum, sacrum, etc., as the next slide demonstrates. The most important takeaway is not memorizing each position, but in understanding the importance of passage and passenger interacting together to complete the labor process. A baby that is in an occiput or back of head anterior position is more desirable than an occiput posterior position because the various diameters of the fetal skull within the various diameters of the pelvis fit more smoothly to accomplish movement through the passage. The fourth P of the birth process is maternal psyche. Marked anxiety and fear can greatly impact a woman's ability to cope with the pain of labor. Stress responses and the release of catecholamines can inhibit uterine contractility and placental blood flow. Positive, caring, nurturing labor support can greatly impact a woman's relaxation abilities and allow her to experience birth in a more positive way. A sense of control, whether through formalized birth plans, childbirth education, relaxation breathing courses, a strong support system, cultural norms, or pharmacologic pain control options can greatly impact patient satisfaction. The nurse should understand and respect cultural norms in order to best assist the patient with her expectations of labor and birth. Page 206 in your text highlights several questions the nurse might need to consider. Lastly, the modern hospital maternity suite has changed the birth experience for many women. Technological advances allow for rapid identification of potential problems during the intrapartum period, but also make for a more impersonal, data-driven process. More technology in the birth suite is linked to higher numbers of interventions, such as instrumented deliveries, surgical births, and infections, each leading to elevated healthcare costs. Technology needs to be used based on risk. Low-risk patients need low-tech births. Typically, the higher the technology, the more the data, the greater the need to act on the data that is gathered, and thus the higher the risk for potential complications. Certainly, technological advances in medicine have dramatically improved morbidity and mortality in childbirth, but remembering that birth itself is not an illness, but a normal process in the woman's lifespan. Several signs that labor is near might be noted by the mother. Mild, irregular uterine contractions, known as Braxton Hicks contractions, become more noticeable. This is a sort of priming by the uterus to prepare for true labor. These often confuse women into thinking labor has begun. However, as cervical change is the only true definition of labor, these contractions may become a nuisance. Increased vaginal mucus is often noted, as well as the sensation that the baby has dropped further into the pelvis. This drop, usually a few weeks before labor begins, is known as lightening and often allows for improved breathing in the mother. But on the flip side, it also puts increased pressure on her bladder and may contribute to worsening dependent edema. Cervical changes, or a type of ripening, may also occur, where softening, slight effacement, and even minimal dilation may be noted. It is important to educate the mother that if ripening occurs, slight, dark, red, sticky vaginal discharge known as bloody show may occur. This is a reassuring sign that the highly vascular cervix is changing, and with it, small capillaries are giving way as progress is made. These next few slides demonstrate the cardinal movements of labor. Each of these movements are determined by the position of the baby and the best fit through the pelvis. As you move through the slides, you will see the descent, engagement, flexion, internal rotation, extension, external rotation, and eventual expulsion that happens. Fetal station is an important component of determining progress in labor. It's often measured during a sterile digital vaginal exam when determining dilation and effacement. It measures the descent of the fetal presenting part in relation to the level of the ischial spines of the maternal pelvis. The spines mark about the halfway point through the true pelvis. We measure station in relation to an imaginary number line drawn through the pelvis, where negative numbers indicate a higher station and positive numbers a lower station. A higher negative station, say -3 to -4, indicates a fetus very high in the beginning of the journey. Dropping through the pelvis, the fetus reaches the spines where we determine 0 station. Here we call engagement and note a fetus well engaged in the journey and in the pelvis. Once past the spine, or 0 station, the number line changes to a +1, with +1, +2 station leading to +3 and +4. At +4 station, we can see that the fetal head emerging out of the labia without pushing efforts. +5 is considered crowning, where the largest part of the fetal head is emerging from the vagina. When an examination is recorded, we often say, for example, she is 8, 100, and +2. This would mean the patient is 8 centimeters dilated, 100% efface, and +2 station. Station is critical for descent. A patient who has a 10 centimeter 100% exam but who is at -3 station is worrisome for a successful vaginal delivery. Labor is divided into 4 stages, each determined by a component of the birth process. The first stage is the dilating and laboring stage. It is broken down into 3 phases that are determined by cervical dilation. Latent, also known as early phase, is from 0 to 3 centimeters. This is often done by the mother at home and is usually the longest phase. According to whether she is a multipara or a nullipara, the length of this stage could be between 4 and 9 hours and is often characterized by mild 30 to 40 second infrequent contractions that eventually progress to moderate strength in every 5 minutes. The mother usually feels well enough to eat, drink, ambulate, talk with her labor support persons, and occasionally even rest. She is rather sociable and may be both excited and nervous. Active phase is from 4 to 7 centimeters and demonstrates an increase in contraction frequency, duration, and intensity until they are about 2 to 3 minutes apart and 40 to 60 seconds long. Typically, they are moderate to palpate. As the mother is working more diligently to breathe with her contractions, she becomes more inwardly focused and is less social. She will often lose her appetite, but will still enjoy labors. Sweating, shaking, with the increased discomfort is often seen. Because labor is well established, it is an appropriate time to seek care from her provider. Transition phase is from 8 to 10 centimeters, and it is the most intense phase. The woman is moving from dilating into pushing. That is why it's called transition. Contractions are very intense, quite frequent at 1 to 3 minutes apart, and they last from 60 to 90 seconds. Women sometimes lose control and begin to panic. They might need calm guidance and support, but they may shun touch and excessive explanations, as sensory overload is common. Panic is often the overriding emotion, and women might need help with focus. The phase usually ends with a large amount of bloody show as the cervix finally gives way to 10 centimeters, and the woman may feel the urge to bear down. This rectal pressure helps to guide pushing efforts of the second stage. Stage 2 is from 10 centimeters to delivery of the baby. It is the pushing stage and may last from 5 minutes to 3 or 4 hours. Stage 3 is the delivery of the placenta, and it is usually less than 30 minutes. The fourth stage is the physical recovery and bonding with the newborn. Friedman curve is often used to plot labor progress. It may help to identify whether cervical dilation is progressing at the expected rate. Along the top, time is noted in hours. Along the y-axis, cervical dilation can be plotted. If desired, along the y-axis, we may also plot station to observe descent of the fetus. First-time moms, or nulliparas, may be expected to change their cervix about a centimeter an hour once they reach 4 centimeters. Multiparas change their cervix on average about 1.5 centimeters an hour from 4 centimeters onward. The Friedman curve helps to determine an arrest of dilation or an arrest of descent.